Now, what I'm about to do is I'm going to give you a framework for understanding the new drugs. Now, this is not for gypsies in diabetes. Okay? This is not for the diabetes nurses. Okay? This is for the rest of us, and the problem the rest of us have is our diabetes nurses come up to us and say, I've seen Mrs. Jones and she needs some of this. And they hand us a prescription, and we look at the prescription and we think, what the heck is that? And then we write our name at the bottom of it. Okay? For those of us who struggle with the new diabetes drugs, this is for you. For the rest of the experts, this is probably not. And actually, we do already have a framework. Here it is. Dead simple. We awarded them a special prize. Okay, so let's look at what NICE is saying with that complicated flowchart. What are they actually saying? What they're saying is that if you see a patient with type 2 diabetes, you need to start these drugs in this order. Now, that doesn't really come as a great surprise to any of us, does it? Okay? That's the red pathway, the pathway we'd always be going up. Right down here at step 1, running all the way across here, and the most important thing in diabetes care is what? Lifestyle, yes. We're not talking about it today because we know what's supposed to happen with that. Struggle to get our patients to do it, but we know about it. So if you see a patient with type 2 diabetes, go up the red staircase. But what the NICE guideline is saying is if you can't go up the red staircase, then you can go up the white staircase. Choose a drug off the white staircase. And then you'll say to me, well, that's all very well, but say I've got somebody on metformin, how do I know when to add in a sulfonylurea? Now, what NICE say is if your HbA1c is 6.5 or more, you step up. Except that when you're stepping up to insulin, they say it's 7.5. Two things to say about that. Are NICE saying that everybody with an HbA1c over 7.5 should be on insulin? No, they're not. But they are saying, have you thought about it? Because there's a decent group of people out there who we haven't thought about insulin who might benefit from it. The second thing is that since these guidelines were published, there's been increasing evidence emerging that really tight blood sugar control, getting everybody down at 6.5 and keeping them there, might actually be harmful. And therefore, actually, we're shifting the targets. That's why QOF has changed. We're now aiming to have people in the 7, 7.5 range, because that's probably safer. And remember, none of these new drugs are more effective than insulin. So you need to be asking yourself this question. Why would this new drug be better than insulin? And if you can answer that question, great, go ahead and prescribe it. But if you can't, maybe you shouldn't be using a new drug. So let's look at our new drugs. Okay, there are 4 classes of new drugs, and what I'm going to do is give you a framework to remember each one by. So let's start with the gliptins. The thing I want you to remember about the gliptins is first, second line choice. All of these new drugs are second line. But of the new drugs, this is probably the one you're going to use most often. And we'll talk about why in a moment. So first, second line choice. Next, let's talk about exenatide and liraglutide. The thing about exenatide and liraglutide is that patients on it tend to lose weight at first. Okay? They tend to lose weight at first. So the thing I want you to remember is obesity. Obesity. Then we've got the glitazones. There's 2 things to remember about the glitazones. Glitazones work by increasing the sensitivity of peripheral tissues to insulin. So we're going to target them at insulin resistors. So how do you spot an insulin resistor? Central obesity, very good, well done. Okay, central obesity is one way. What's another easy way of spotting somebody with insulin resistance? Yeah, hypertension might be. Dyslipidemia, most diabetics are dyslipidemic though, aren't they? So that won't narrow down our field.
Poor response to glyphosate?
Poor response to glyphosate could be one of them. Something very simple though. If these people are on insulin, how much insulin are they on? Loads. This is your patient who's, I've got one on 72 units of Insulatard. Okay, he's an insulin resistor. Okay, so think insulin resistor, but as you're aware, these drugs are associated with some harms as well. So you need to also ask yourself, do the benefits outweigh the harms? Because, you know, part of diabetes is insulin resistance, isn't it? And actually, it's also about picking out those insulin resistors that would really benefit. And then finally, insulin secretagogues, repaglinide and nataglinide. The thing you need to remember about those is that they're not loved. These drugs have been around for ages, but they're not widely used. They're not covered by any NICE guidelines, so they're not NICEd and not in liver disease. They're excreted in your bile. Okay? So I think there are only 4 classes of drugs, so only 4 things you need to remember. But as somebody pointed them out to me, he said, well, actually, what you're saying is don't use these drugs. Okay? What you're saying is don't use these drugs. So actually, you only have to remember 2 things. Okay? Not quite what I'm saying, but good start. So let's just see, how do you get on? If we say gliptins, what are you thinking? First, second line choice. Good. Okay, if you think about liraglutide and exenatide, what do you think? Good. Glitazones? Insulin resistor. Do the benefits outweigh the harms? Good. Repaglinide, nataglinide? Yeah, not. Okay, simple way. Not liced, not liver, not loved. Okay, so that's a framework on which to hang this, so that you've got all of that in place and you can hold on to that. Now, what we're going to do is go through each of those 4 drugs and look at the framework and understand why the framework says what it is. So let's start with the gliptins. The thing we're remembering about the gliptins is first, second line choice. Where do they fit in our framework? They fit at steps 3 and 4. And that's where we might use them. So these are tablets, remember, and there's minimal risk of hypos, and that's really important, particularly for our drivers, that's there. And for all of these drugs, NICE set us criteria. They say in the first 6 months of use, you need to drop your HbA1c by 0.5% if you're going to carry them on beyond 6 months. In terms of side effects, headaches are common. They tend to wear off over 8 to 12 weeks. Warn your patients about them. They'll be able to carry on through them. Weight neutral, small weight gain. Be careful in renal impairment. They've got different licenses according to the level of your EGFR. And the costs there. How many people think that's cheap? How many people think that's medium cost? Expensive? Yeah, metformin costs £17 a year. Sulfonylurea is £35 a year, insulin £35 to £199 a year. So these drugs are relatively expensive. Doesn't mean we shouldn't use them, but relatively expensive. So that's the gliptins. Exenatide, liraglutide, obesity is the thing we're holding on to. And exenatide and liraglutide fit at step 4 in place of insulin, and you'll see why when we look at costs. They're also injectable. That might be another reason you're not going to be jumping in there early. Hypo risk may be lower than insulin. And the criteria NICE set are stricter. You need to drop your HbA1c by 1% and get a fall in your weight of 3% whilst you're using them. And that's why we focus on the obese patients for these drugs. Nausea and vomiting are common. 50% get nausea, 20% get vomiting. And in the context of a clinical trial and all the extra support patients are getting to carry on, still 16%, 16% will stop. And look at those costs down there. These drugs are expensive. £830, that's exenatide for a year. £1,400, that's liraglutide for a year. So glitazones, we're remembering insulin resistor. Do the benefits outweigh the harms? And these drugs fit at step 3, 4, and 5. I think that's not because they're any better. They've just been around for longer. We've got a bit more experience with them. They're tablets, of course, which again is helpful. So hypos are rare. The latest evidence suggests they may be the lowest risk of all the oral hypoglycemics in terms of hypos. A criteria NICE set are the same as for the gliptins, so drop your HbA1c by 0.5% in the first 6 months if you're going to carry it on. And pretty well tolerated. GI side effects are the commonest side effect. Remember, you do need to check liver function. There have been rare cases of liver disease, liver failure in these individuals. Costs there are similar to gliptins. But of course, one of the issues with this drug, rosiglitazone had its license suspended, pioglitazone is the only drug still available. One of the concerns about these drugs is about other issues. The latest is from the MHRA, is about bladder cancer. They say that in people who've had bladder cancer, these drugs are absolutely contraindicated. So if you know you've got somebody, or you don't know and you're worried you might have somebody on a glitazone and on who's had bladder cancer, it's worth doing a search for that and checking. They also say if you have hematuria, you should investigate it promptly. Heart failure, these drugs are absolutely contraindicated in heart failure, but they also increase your risk of getting heart failure. In terms of cardiovascular disease, some trials have shown that these drugs are cardioprotective, some have shown they're cardio-neutral, and some have shown they're cardiotoxic. So quite where the truth lies, we don't know. And the final one is odd. It's fractures, only in women, but it's not osteoporotic fractures, it's distal arm and leg fractures, and we don't know why that is. The MHRA have said we should review every single patient on a glitazone to make sure they're on the most appropriate treatment. And you need to make sure, particularly if you're not doing the diabetes care in your practice, if your nurses are, that that has happened. So that might be something for your action plan, to make sure you've reviewed every patient on a glitazone. And finally, let's think about repaglinide and nataglinide. These don't appear anywhere in the NICE guidelines. They're tablets. They do cause hypos. And we haven't got, as I say, any recommendations. One of the reasons they're not widely used is that they cause rashes, urticaria, hypersensitivity. And that can be quite a big issue with them. And remember, these are excreted in your bile, so any liver impairment, you can't use these drugs. Some of them you have to be careful with renal impairment too. And the costs are similar. So, remember that none of these new drugs are better than insulin. They're as good or nearly as good as, and we don't have good long-term data on them. We should use them targeted for specific patients that we can identify, and you can use the framework to do that. So if I say to you, gliptins, what do you think? First, second line choice. Good. If I say to you exenatide, liraglutide, good. Obesity. Glitazones? Insulin sensitivity? Yeah. Do the benefits outweigh the harms? Good. And repaglinide and nataglinide? Good. Okay. I hope that's given you a framework to understand the new drugs. Good. Okay. Have a look at this then. What I want you to do is I want you to divide into threes. How should we do this? Let's say all of those people at the back there, you're the top case scenario. Middle group, middle case scenario. This group, bottom case scenario. And that includes right up at the back. And what I want you to do, in pairs or threes, I'm going to give you 2 minutes to go through your case and work out what the issues are. So you've got 2 minutes. 2 minutes. Okay, so let's have a look at some of these cases. So, our first case, 52-year-old, type 2 diabetes and hypertension, works as a roofer. There are his vital statistics and there are his drugs. What sort of things are going through your mind when you think about this individual? Okay, so is his diabetic control okay? What do you think? No. Okay, so what are you going to do about it? He's on metformin, he's on a sulfonylurea. On our traditional pathway, where do we go? We go metformin, Sulfonylurea, insulin. Okay, he's a roofer. We don't want him balancing on the top of the roof without his hard hat on an icy day having a hypo. So insulin for him might not be ideal. So what might you choose? A gliptin. Why a gliptin? Because it's my first, second line choice. Yes, good, okay. Nothing like rote learning. Why else?
The risk of hypos.
No risk of hypos. Not no hypos, low risk of hypos. Good, okay. What else? Blood pressure. Do we like his blood pressure? No. What are you going to do? ACE inhibitor. Very good. Give him his renal hug as well as his cardiovascular hug. Good, okay. That's probably the key issues. Okay. Oh, would you stop his indapamide? Well, we can't get indapamide anymore, can we? So we're going to have to stop it. No, I wouldn't stop it. I'd put him on. I'd keep him on indapamide if it was available, or Bendro would be fine. Okay, can you use a gliclazide with a gliptin? The thing about the new drugs is that they're all licensed. Well, one gliptin is licensed for monotherapy. Why you'd want to use it in the monotherapy, I have no idea. All these new drugs are licensed for either dual or triple therapy. Dual therapy is where you use an old drug with a new drug. Triple therapy is where you use 2 old drugs with a new drug. Okay? They've all got slightly different licenses. And what's really interesting is they're widely used outside their licensed indication. Okay, so that would be fine. Okay. So next one, 75-year-old man, type 2 diabetes, just registered. Always a bit tricky, people who've just registered. You know, is this a GP who has tried everything, and this is the combination that works best? Or is it a GP who goes out to lunch with a drug rep every Friday? So, there's their vital statistics, there's their drugs. What are you thinking? Why isn't he on metformin? Brilliant. Okay, who's giving him a hug every morning? Okay. Now, he might be in renal failure. Okay, that might be why, but it's worth asking the question. Good. What else? Yeah, we're going to stop his repaglinide. What do we think about repaglinide and acteglinide? No. Not nice, not loved, not liver, probably not. Okay, what else?
BMI.
His BMI. Okay, so we're going to put him on metformin. He's on sulfonylurea, traditional pathway, metformin, sulfonylurea, insulin. What happens to people with a BMI of 39 who you put on insulin?
BMI goes up.
Yeah, next week their BMI is 45. Okay, not good. So what might we use? Exenatide. Why? What do we think about exenatide, liraglutide?
Obesity.
Obesity, good. I have a patient with a BMI of 44 who's happily gaining weight on his exenatide, okay? But they do generally lose weight at first. Okay, good. Anything else? Yes, atorvastatin 40. Why is he on 40? Is that because he needs it to get his cholesterol down low? Or is it just his GP's done a switch from simvastatin when the MHRA guidance came out about amlodipine and then didn't realise that it's not equipotent and that 10 is the actual recommended equivalent dose? We could find out. Anything else? Yeah, he's not on an ACE inhibitor, but he doesn't need it because he's got the most fantastic blood pressure.
Depends what his ACR is.
Okay, so it depends what his ACR, yeah, he might need it for that. Now, how many of your diabetics on no antihypertensives have a blood pressure of 128 over 62? None. Okay, so when you see a blood pressure like that, what do you think? You think, phew, I've hit my QOF target. What else might you then think if you stopped thinking and stopped and thought about it for long enough? What might you think? He's ill. Okay, so there might be something wrong with this guy now. What in particular might be wrong with him? Yeah, he could be in heart failure. Good. He could have peripheral vasculitis. He could have autonomic failure. Yeah, good. So I want to ask him about his erectile dysfunction. I might warm up to that question first before jumping straight in. I want to ask him if he gets terrible bloating after a meal and vomits after a meal because he gets gastroparesis. I want to ask him if he gets up in the middle of the night and has diarrhea. Another sign of autonomic failure. If he doesn't, he's about to, because you're just going to prescribe him some metformin. I'm going to ask him if he's lost his hyper-awareness, because if he has, that has major implications for driving. So a blood pressure as good as that, think autonomic failure, and that's a real sign you just need to tighten up their control. Good, okay. Last one, 68-year-old, returns after an NHS health check. Don't you just love them? No past medical history, aspirin, and there's his vital statistics. What are you thinking? He's got pre-diabetes. Now, this is where you need to be really careful. In the past, we did HbA1cs only in our diabetics. So there is a real risk that when filing my blood test first thing in the morning, I write, excellent diabetes control, keep up the diet and lifestyle. Okay? He hasn't got diabetes. So it's really important when you look at your blood results, you see whether they've got a diagnostic code of diabetes before you congratulate them on their fantastic control. Okay? So he's not diabetic. Okay? So you can't write fantastic, well done. He's got pre-diabetes. We'd want to do some confirmatory tests, but if that turned out to be the case, what would you do with him? Lifestyle. Most important thing. Most important thing. Try and get him back to normoglycemia. Good. Yes, put him on some metformin. Give him a cardiovascular hug. Good. What else? Stop his aspirin. Okay. Aspirin in primary prevention, diabetics, Q-risk over 20%, rest of the world, if they haven't had a heart attack or a stroke, the number needed to treat is 1,666. For this guy, you have to treat 1,666 people like this guy every day for a year to prevent one cardiovascular event. It ain't worth taking a tablet for that level of benefit. Secondary prevention, absolutely. Once you've had a heart attack or a stroke, the NNT is 66 for a year to prevent one cardiovascular event. That's worth doing, okay? We'll stop his aspirin. Except, of course, you might want to ask whether he's been on it 5 years or not yet, because for first 5 years you're on it, you get a benefit in terms of your cancer risk, okay? So that might be worth thinking about. Good, but stop that in terms of diabetes. Good, what else? One other thing.
Blood pressure.
Yeah, blood pressure, do we like that blood pressure? Yeah, actually, given what we've said earlier on, that's probably okay in pre-diabetes. Okay. Something else? His weight. BMI of 29, what might you offer him? Yeah, he does qualify for some orlistat, okay, with good counselling about it. Okay, any questions on that? Yeah. I can't hear, sorry, can you really shout?
There's no guidance for treatment levels for primary prevention of lipid control. But in diabetes, is there any guidance?
Okay, so the question is about cholesterol in diabetes, is that right? Okay, so it depends which guideline you're following. If you follow the NICE guideline takes the approach in diabetes that you should try and get the cholesterol down under 4 and the LDL down under 2, but it does say that only 50% of people will get there. The Scottish guideline, so that's what we call treat to target, and that's what we do in secondary prevention. The Scottish guideline, the SIGN guideline, doesn't do that. It just says if you're over 40, stick them on a cholesterol-lowering drug, a statin, and actually you don't really need to measure it again. That's what we do in sort of more primary prevention type things, okay? And actually you do get your biggest win for the first big reduction you get in your statin. So you need to make a decision where you go. But basically they need to be on a statin. Okay. Good, well done. Okay, so I hope that's given you a kind of real practical framework to use with your diabetes patients.